All right, we're going to go ahead and get started. Come on in. We got seats down at the front. We got seats all around. Welcome, everybody. Once again, I'm Andrea Nicoletta. I'm at the Vermont Department of Health, and I'm so excited to be here with all of you to talk about financing and sustainability, one of our 5 key areas that we discussed this morning. So with us today, we have 2 fantastic experts. I'm going to go ahead and introduce them both right now and then turn the mic over first to Carl, who you can see on the screen, and then to Tara, who will be here with us in person. So Carl Rush, MRP, his has specialized in policy and workforce development for community health workers since 1996. He has advised CHW policy initiatives in more than 25 individual states. He is formally advising on Medicaid SPA discussions for CHW services in a lot of state acronyms that I don't have spelled out and don't know. So we're going to, in many states, including Vermont. I should have checked that. He was a lead author on HRSA's 2007 CHW National Workforce Study and co-lead on the CHW Core Consensus C3 project 2013 to 16. Carl completed 2 national policy studies with the CDC on CHW certification and workforce development strategy, and was a founding member of the National Association of CHW's Board of Directors, and is currently serving as a policy advisor to NASHWA under contract. Tara Murphy is here with us as well. She, her works at the intersection of healthcare, social services, and public health. Her favorite challenge to take on is translating aspirational goals into high impact initiatives, often within impossibly short timeframes and amid stakeholder scrutiny. I'm sure that doesn't ring true for anyone else in here. Tara does this in part by building tiny bridges between groups that have traditionally been siloed or distant from one another, so that projects can draw upon a variety of experiences and mindsets, and everyone can collectively achieve a more ambitious agenda for health systems change. We are so grateful to both of our experts to be here to share their wisdom with us so we can learn with and from them. And with that, Carl, I'm going to turn it over to you.
Okay, great. Thank you. And hi, everybody. Great to be with you, at least partly. I'm grateful to the organizers for making this technology available. I was told it might be a little dicey to try to get to Montpelier in this at this time of year, so it's probably discretion is the better part of valor. I'm going to start sharing my screen. I'm also very happy, of course, to be sharing the panel with Tara. We have worked at least briefly together around issues in Massachusetts, and I will, in the interest of time, get started, making sure you can see my screen. It looks like you can. It's great to be able to see you all. Unfortunately, I'm looking at the back of your heads in many cases, so it's a limited benefit, but it's appreciated. So I'm going to just plunge right in here. The issue is one of not just sustainability, but scaling. In most states, there are a fair number of community health workers already active, but it is difficult to build up the level of the scale of the workforce that we really need to address community health issues. And I would point out just briefly that nobody's really gotten a handle on what the quantitative goal is. How many CHWs is enough for a state? So just want to sort of pin that thought. We're trying to discuss that at a national level, but it does make it difficult. We all want more sustainable support for more CHWs, but how many are we shooting for? This is going to be an interesting conversation. But sustainability is about more than just financing. It is about making available the infrastructure and supports in organizations so that community health workers can achieve their full potential and impact. With many organizations, they may have 1 or 2 grant-funded CHWs, but are they ready to absorb a larger number of CHWs at a greater scale? For some organizations, they're just starting out. This can be a challenge for for healthcare organizations in particular. How ready are they for the kind of change that CHWs represent? It is absolutely vital that CHWs receive appropriate supervision. We use the term reflective or trauma informed. We don't really have time to talk about what that is or why, but can't just anybody supervise a community health worker effectively. And I think it's important to be looking towards that as part of the infrastructure, if you will. Who's going to invest in workforce development in Vermont? How much is the responsibility of employers? I think most people agree that community health workers should not be expected to bear the full cost of their education to develop their skills. And then lastly, it's really important to do a good job of evaluation. We have some colleagues who are doing some excellent work at the Common Indicators Project to try to develop methods and metrics that are most helpful for this field. So we're building on, when we talk about sustainability, we're building on a lot of work in prior years. One of the most influential was the one in the middle, which is from the University of California in 2006. But there's been a lot of other folks with sticking oars in the water, so to speak, to help build our knowledge base about sustainability. It is challenging. There's no two ways about it. Of course, the elephant in the room is Medicaid. And that is the focus of a lot of efforts in this arena, and understandably so. There's been a huge expansion of interest in Medicaid financing for CHWs, and a lot of it was stimulated by COVID. As we would say in Texas, COVID was kind of a 2x4 upside the head for people who didn't realize that community health workers were absolutely essential to population health and community empowerment. And they have learned, I think it's not too late to learn these lessons, but it's really been significant. About 20 states have either 1115 waivers and or state plan amendments. And those are two different vehicles. If anybody wants to talk separately later on about the difference and why they are chosen, we can do that. But I will talk a little more about state plan amendments specifically in a minute. We're learning a lot and from the peer support specialist movement, and about 40 states already have Medicaid financing for them. What can we learn from them? We just had a really interesting conversation between CHW leadership and peer supporter leadership a couple of weeks ago that was convened by the Federal Office of Minority Health. And they are very committed to the idea of CHW sustainability. So they're doing a lot of good stuff to help us in this effort. But you all may realize this already. It's certainly very possible. Medicaid alone is not the answer. What we would call that in terms of logic is it's necessary, but not sufficient. It's a huge source of funding, but there are definitely limits to it, which we can talk about in a minute. So I do want to emphasize the value and importance of thinking about blended or braided funding. If Medicaid is not the only answer, what can individual organizations do? What can communities do to kind of blend different sources, including Medicaid? Because you can then support a broader range of services to broader populations. There are some things Medicaid just won't pay for, and Medicaid only pays for services to Medicaid recipients. And so that raises a lot of concerns for communities as a locus of this activity. So it's important to combine a long-term source like Medicaid, and there is increasing interest from Medicare, by the way. I'm not really going to dwell on it, but the CMS just issued a request for information as part of their physician fee schedule determinations. They have asked, what should Medicare be doing to pay for CHWs? Well, I'm glad you asked, we said. Anyway, it's combining these longer term sources with a sort of cycle of shorter term grants and contracts. There is a lot of interest in the federal government in areas like chronic disease, behavioral health, maternal child health. And can we harness the vehicles that have been created in community service block grants, community development block grants to include CHWs. But there are also a whole raft of diversified sources, particularly in housing and education, workforce, economic development, et cetera, that can benefit from what CHWs can achieve in the community with very much the same populations. So it is a great opportunity right now to try to create these kind of blended funding systems. And as one example of this, and it's not the only example, but many people are familiar with Pathways Community Hub system, which is they have sites going in, I think, at least 20 states right now. And some of the core features are that the community hub, which is not itself the employer of the CHWs, manages the partnerships and handles all of the billing to a diversified set of payers. The community health workers are primarily employed by community-based organizations, which in many ways is as it should be. And the CHWs receive a referral, work with the family to assess their situation and set goals and negotiate an action plan to reach those goals. They work using protocols called Pathways, and there are 20 some odd of them right now. But it could be anything from a pregnancy pathway to a diabetes pathway, to a housing pathway, to an employment pathway, a childcare pathway. You know, there are all kinds of things that CHWs can follow with these families. And their progress in terms of completed steps on those pathways is the vehicle for the hub to invoice the payers. Okay, so the individual employer of the CHWs does not have to handle billing. And that's a big help to a lot, particularly smaller organizations. So the payers include a diverse group of organizations, even including in several sites United Way, who make these payments through the hub for a diverse set of CHW activities. And this is how they depict it as a graphic with an array of payers. A lot of this stuff is involved in serving older populations. So the Area Agency on Aging may very well be involved in it. And there are some of these models that are being funded through the Administration on Community Living, which is an interesting partner in all this. And then on the bottom, the little orange circles are the participants in actually delivering, so that they can have one care coordinator working on a diverse set of goals for each of these individuals or families. I mentioned Medicaid state plan amendments. This is where a lot of the action is right now. The states in blue are those that have, there are 10 of them that have active state plan amendments right now. It's very interesting that half of these were just approved earlier this year. So this is a growing movement right now. There are probably 8 or 10 states that are actively working. Those are, at least some of them are coded in yellow here, states that are actively pursuing the idea of a state plan amendment. Most of these states start with fee-for-service payment just because they don't have enough data to justify rates for other forms of payment. There is one exception to this right now, but one of the encouraging things is the most recent ones have taken a much larger view of the things that they should be able to pay for, the kinds of activities that CHWs undertake. And a number of states, I don't want to dwell on this either, but there was a phenomenon a few years back called delivery system reform incentive payment waivers. And several states had some very interesting things developed under those waivers, some of which are ongoing now. And if I have time later on, I'll talk about the example here in San Antonio. There was a rule change in Medicaid effective in 2014, which a lot of these states are relying on, and they can justify, as some states explicitly have, is that prevention can be primary, secondary, or tertiary, which means that you can justify almost any kind of activity as being preventive. It's either preventing a condition early on, or it is preventing the further development or continuation of that condition, which might be considered tertiary prevention. Interesting that most states only have one billing code that is authorized for these services, and in many of them, it is the same code that Minnesota pioneered in 2008. There are a lot of lessons learned that we may be able to discuss later on. I will have a publication coming out very soon from the National Academy for State Health Policy, NASHP, about the patterns and trends in these 10 state plan amendments. And we were about to come out with it earlier in November, but we found out about Maine, and we had to go back and make sure that we included them because Maine is the 10th state to be added to this list. So some of the things that they're doing with these state plan amendments, try to be real quick here. Rhode Island is a very interesting one. They've established a broad definition of medical necessity, or how a recipient qualifies to get CHW services, including going so far as the recipient being able to self-declare, hey, I need the help of a CHW. That's enough for Medicaid to pay for those services, which is pretty cool from our perspective. Louisiana is mainly relying on health plans, and Virginia and South Carolina are likely to do that in the near future. That is also a trend. They're looking at a different billing code for the federally qualified health centers, who will be able to, as in several states, the FQHCs will be able to bill outside of their prospective payment system billing. Minnesota, as I said, was early. We note that they are allowing diagnosis codes from the ICD-10 Z code system, meaning that the patient is identified as having an issue with one or more of the social determinants of health. And interestingly, in Minnesota, the employers can bill the state directly, but if they have a contract with a managed care plan, they can bill that managed care plan, and some of them indeed have negotiated a higher hourly rate from those health plans than what the state pays. The billing rates, these are not what the CHW is paid, but the fully loaded billing rate, which we may be able to talk about later, but it includes a lot more than the actual wages paid to the CHW. Most of them have billing rates equal to about $50 an hour, but it ranges a lot. South Dakota just raised theirs to $62 an hour because it's a big, very rural state, and they realized they were going to have a lot of non-billable travel time that had to be covered somehow. And then very interesting in California, Massachusetts, which Tara may comment on, and Maine very recently, they're planning to finance primary care services, or some aspects of primary care, through capitation, or per member per month payments, rather than fee for service. So this is a really crucial comment here. There are some things that the state is going to have to make decisions about that can profoundly affect the work of CHWs. I'll go through this real quickly, but this is also addressed in the Medicaid 101 thing that we're going to talk about later. What services, of course, will be covered. The state is, in most cases, going to impose some limits on how many hours per day or per month, per year the CHW can spend with an individual, what, of course, the hourly rate of pay would be, in what settings. Interestingly, some states do not allow CHWs to practice in a clinical setting. Some states don't allow them to practice anywhere else but a clinical setting. That is a really interesting set of decisions. In all cases, CHW services must be ordered or referred or recommended by some form of licensed clinician. But depending on what authority they use, they invoke for their state plan amendment, they may have to be supervised by a licensed clinician, but that's not true everywhere. And then lastly, and this is a really crucial issue, community-based organizations employ a lot of CHWs in any state. And it has taken an extraordinary effort to try to make sure they're included in some way, and we can talk about how that might work, so that they can participate and not be shut out of this. I think most of us agree that healthcare organizations should not be the only ones able to receive Medicaid payment for CHW activity. So lastly, I want to close with, you're going to hear more about this later, but we're going to be offering a Medicaid 101 webinar, one session for CHWs and one for a sort of mixed audience of CHWs and allies and so forth. So that's my quick shot. I'm going to turn it over to Tara, and I look forward to our discussion about all of this. Please do jot down your questions from my remarks so you can remember them after hearing from Tara. But I appreciate the opportunity to speak with you. I'm trying to get my cursor to appear so I can stop sharing, and there we are. So again, thank you. And I'm not hearing audio yet.
Thanks so much, Carl. We were muted, but you got a lot of applause.
Okay.
Hi, everyone. I'm just going to get my mic set up here. Can you all hear me? Great. So I'm Tara Murphy. I am really glad to be here with all of you today, and really glad that Carl could join us from Texas. We worked together a little bit in the past. You know, I have a tough act to follow. Carl is really the guru of CHW financing. My perspective is a little bit different. I don't have the same, by any means, the same comprehensive kind of national view of things. But I have spent a lot of time over the past 5 or 6 years thinking a lot about the CHW workforce, and in particular, how to create a well-prepared, sustainable CHW workforce for our state. So very briefly, I spent about, I'm from Massachusetts. I spent about 5 years with the Massachusetts Medicaid program, what we call MassHealth, heading up something called the Statewide Investments portfolio, which was a key part of MassHealth's Section 1115 demonstration waiver from the period 2017 to 2022. So this goes back pre-COVID. Important to know. As part of that, my role at MassHealth, I, along with my team, designed and ran numerous programs that, again, were aimed at getting at that well-prepared, sustainable CHW workforce for the state. Importantly, I, along with my team, also designed much of the workforce section of the waiver that came into play following that 2017 to 2022 waiver, which continued our investment in CHWs. I have been working as an independent consultant for the past year, 18 months. I'm currently involved in a bunch of work that brings me quote unquote near to Medicaid investments in CHWs, most notably in Rhode Island, with a little bit of the benefit that Carl was talking about, and most recently California. Both states have state plan amendments that support reimbursement for CHWs through Medicaid. So not surprisingly, my talk will be very Medicaid centric, if you will. I've been a little bit overly ambitious in the number of slides that I put together and the material that I would ideally love to cover. So I'll get through as much of it as I can. Again, there's a couple of themes, a few themes that kind of weave through this. And this is really sort of me, not comprehensive overview, but me talking about my own kind of on the ground perspective, working on CHWs in a couple of states within the Medicaid context. Again, take this for sort of a statewide sort of window into this larger question. To kind of double down on one of Carl's points that he made early on, sustainability is really more than just financing, right? We're here, the focus here is financing those CHW positions, but creating that sustainable workforce is really a lot more than that. A couple of must-haves for Medicaid. again, part of my role in the past handful of years has been quote unquote selling investments in CHWs within Medicaid. So just a couple of pointers there. And then if we can get to it at the end, again, in my perception, states kind of have their own unique mental models or personalities in terms of how they think about healthcare payment, healthcare restructuring and reform. And that makes a difference in terms of how they might approach financing and sustainability for CHW positions. So I'll again start at the beginning. I'll try to move through the technical piece as quickly as possible, but again, it sets the stage for how we got to financing for CHWs in Massachusetts. And the short version is of financing for CHWs in Massachusetts is we kind of did it by accident, right? We didn't set out to finance a whole bunch of CHW positions. What Massachusetts started, really the intention with their 1115 waiver going back to the work we were doing in 2016, leading up to a launch in 2017, was trying to reach the goals of decreasing total cost of care for MassHealth members. At the time, MassHealth was about $16 billion and continuing to increase. So we wanted to decrease that total cost of care at the same time as improving health outcomes for a MassHealth member population, which has typically hovered at around 1 million people in Massachusetts. So taking a quick step back, an 1115 waiver, just to kind of fill in the details and give a definition very quickly, is you can think of it as permission from the federal government to do your Medicaid program a little bit differently. So write a proposal, say we sort of want to make a shift in this way, and the federal government, typically after a period of negotiation, will hopefully approve most or all of what you've proposed to do. 1115 waivers are not unusual. I think many, if not most states have them. What we were doing in Massachusetts was somewhat different in that we went really big with our 1115 waiver. Instead of sort of experimenting in a section over here, we decided to, with the goal of decreasing that total cost of care and improving health outcomes, let's pull apart our Medicaid payment and care delivery system and put it back together again in a new way. The way that we sort of reorganized our Medicaid delivery system was to take individual Medicaid providers, the vast majority of them, and reorganize them into what turned out to be 17 new accountable care organizations. Those 17 new accountable care organizations were charged with, again, decreasing that total cost of care and improving the health outcomes for the MassHealth members and the patients that were assigned to them. What we were trying to do with this big endeavor is reach these goals, but do that by making this, again, very wholesale and ambitious shift from orienting the healthcare system from a traditional fee-for-service incentive basis in which healthcare providers are funded primarily for prescribing more services, right? And so if you sort of think about healthcare policy, the ballooning healthcare costs in the United States, many economists and healthcare policymakers will tell you that the incentives are set up wrong. They're set up to incentivize healthcare to simply provide more services, get paid for prescribing more services, and not necessarily reward keeping people healthy. The alternate to that is something called value-based payment, in which healthcare providers are rewarded for keeping costs down, but also helping their patients become more healthy and helping them maintain better health. And to the extent that they can achieve health in the patients, they will get rewarded, better rewarded financially. So what we were trying to do in Massachusetts was really sort of go from fee-for-service volume-based payment almost overnight, within 5 years, all the way over to value-based payment. We had, and Carl mentioned this a little bit, we had some new money coming in to support this, $1.8 billion in something called DSRIP funding, so Delivery System Reform Incentive Payments, that were sort of contributing to this big endeavor and helping, again, providing that sort of funding support to shift this dial of the Medicaid system almost wholesale overnight from volume-based fee-for-service over to value-based payment. This $1.8 billion is really kind of important to keep an eye on. I talked about the 17 new accountable care organizations as being the big vehicle for this shift in payment and care delivery orientation. Of this $1.8 billion that was coming, new money that was coming into the Medicaid system in Massachusetts, $1 billion of that, so more than half, went directly to these 17 new ACOs over a period of 5 years. ACOs had the discretion to use this money, obviously within parameters set by MassHealth and upon approval by MassHealth Medicaid, but really had pretty far-ranging discretion to use this $1 billion in funding to make investments in whatever they thought would enable them to better care for patients, shift their orientation of their healthcare delivery system, and achieve those goals of total cost of care, reduce total cost of care, and improve health outcomes for their members. Types of investments included maybe integrating electronic health records, investing in data systems and data exchange systems, hiring new types of healthcare workers, maybe more doctors, more nurses, creating programs that might sort of address patients with diabetes, or investing in behavioral health, primary care integration. So a whole host of ways that they could spend this money. I'm just going to take a quick look at what an ACO actually is, right? And I promise I will get to community health workers at some point for the next couple of slides. Quick look at what an ACO actually is. The whole thing is contracted with a payer, in our case, Medicaid. There's a management level that makes decisions about sort of how do we run this entire system, right? You have, and that could include a health plan, doesn't need to. You have your layer of provider organizations, so typically primary care practices, and those provider organizations are charged with providing the care for patients or the members in the ACOs, right? This management up here is where the $1 billion was budgeted and funded. ACO management, to different extents, could push that money down to benefit the providers, to enable them to do a better job of caring for those patients. So we'll come back to this at some point later. My part in the 1115 waiver was to run the statewide investments portfolio. This was $115 million designed to design and invest in programs that were intended to create the conditions statewide that made it more likely for those ACOs to be successful. The way I often described it was, you can have the best designed ACO in the world, but if you don't have the doctors, nurses, medical assistants, and so on to work in it, it's really an academic exercise on paper only. It's never going to get you to those outcomes that you want. Much of my portfolio centered on improving the healthcare workforce in various ways. And the first task for my team when we stepped in 2017 was to figure out what the on-the-ground conditions were, and then to design programs that would be capable of sort of addressing those gaps and those barriers, again, with that ultimate vision of that North Star of helping those ACOs decrease the total cost of care and improve health outcomes for their members. When we started doing our legwork, we spent a lot of time talking to just about everybody that we could walk through the door and would take our calls or let us in their offices. We learned very quickly that clinical providers, right, so these provider orgs here, we're talking pretty endlessly about the need for CHWs, the need to hire more CHWs so that they would have that connection to the community to bring in those members that they were now accountable for, but that may not have been connected with with their healthcare organizations because they're from communities that may be more distrustful of the healthcare system, disconnected from the healthcare system, less able to get to the clinic, right? So we heard a lot about CHWs from clinical providers. When we talked to ACO leaders, so the group sitting up here, they were also talking a lot about CHWs for the same reasons, also because they had read a lot of studies about the cost effectiveness and impact of CHWs. So we're hearing a lot about CHWs from the ACO leaders. And then when we looked at the ACO budget, so how that, what ended up being at $1 billion was being spent, we saw lots and lots and lots of CHW positions. It was basically a CHW hiring extravaganza that was happening across Massachusetts. And the distinct impression that we were left with was, you know, everybody is thinking that CHWs are going to save healthcare in Massachusetts. And I would often add with a little bit of sarcasm on $12 an hour. So a couple of key points, right? Again, as I said before, we kind of stumbled into to financing for CHW positions in Massachusetts with this $1.8 billion in new money for Medicaid restructuring that hit the ground in the period of 2017 to 2018. What's really notable is this isn't a decision that was made at the top level of Medicaid policy. It was Medicaid policy was busy designing financial incentives to shift the care delivery system. This push to use that money to hire community health workers at this kind of massive, never seen before scale came from the provider organizations themselves, the people who are the groups that were working directly with patients. We often, another point of distinction, we often talk about, and one of the big problems with the community health worker workforce, especially in the US, has been historically been that patchwork of grants that has funded community health worker roles. This was time limited funding for CHW positions. It's true, it's 5 years, but it's very different from that patchwork of grants in that it was kind of hiring on a massive scale, right, across the state all at once. And it was tied to this much bigger healthcare reform restructuring initiative, which meant that it was kind of embedded in something different, in something bigger than itself, right? It wasn't sort of a community health center over here with a grant from a local foundation, another one over here doing their sort of one person CHW projects. It was something that the state as a whole was thinking about. And because it was embedded in a demonstration waiver to the extent that CHWs were deemed to be sort of helpful in the success of that waiver and that sort of massive experiment, the state as a whole would be looking at how can we sustain these CHW positions. I'm keeping an eye on the time, but I want to stop really briefly on sustainability is more than financing, right? This was a massive opportunity. Thank you. This is a massive opportunity for CHWs in Massachusetts in that in much the same way that I think the pandemic sparked this like just huge spotlight on CHWs and really pushed to hire CHWs. Our 1115 waiver back in 2017 kind of did the same thing for our state, right? So it was prime time for CHWs. When I say we, those of us thinking about, my background is community health, right? So that's kind of my starting point for US-based healthcare. So those of us in the community health world and those of us who think a lot about the healthcare workforce, we really wanted to see community health workers succeed now that the spotlight was on them. And we knew that there was a risk of that not happening, given the fact that the community health worker role is still, I would say, relatively new in US-based healthcare. I also have worked in global health where community health workers are much of sort of a more known factor. In large part, I think, again, my personal opinion, the community health worker role itself is kind of, as a sort of culture and ethos, is somewhat at odds with the US healthcare system, right? So if you think about defining characteristics of US healthcare, it's very hierarchical, places a really high value on academic achievement and credentials, letters after people's names, right? And there's this big emphasis on productivity. Time is counted in these, the kind of tyranny of the 15-minute patient visit if you talk to any primary care physician, right? By contrast, community health workers have this kind of ethos of community and accompaniment, right? So instead of being this hierarchical relationship, they walk arm in arm with the people that they're helping. They're hired based on not the letters after their names, but lived experience with trust within and understanding of local communities, and then this personal characteristic of really being a natural helper. So again, that's kind of at odds with letters after your name and sort of how high have you climbed the ladder. And then again, the way they do their work is not the 15-minute patient visit. It's this emphasis on developing a trusting relationship and meeting people wherever they're at, regardless of how long that takes. So if you're sort of plugging community health workers in to this hire and expecting them to work in this community health worker type of way, plugging them into this hierarchical healthcare system with kind of nothing mediating that, it could be a recipe for things not going so well. And what we didn't want to have happen in Massachusetts was, again, this mass hiring of CHWs and then kind of a culture clash where they don't live up to their promise. And so I won't dwell on this, but we basically, over a lot of talking and thinking within my little corner of MassHealth and working kind of arm in arm with colleagues in the Department of Public Health, Office of Community Health Workers, headed up by Gail Hirsch, who is just tremendous and kind of the goddess of all things community health worker, as far as I'm concerned. We came up with this kind of framework where there's a lot of support for community health workers at the level of community, right? So core competency training, advanced trainings, so that they come into the healthcare system kind of armed with some good understanding and training behind them. Financing for the CHW positions, which we started with first in Massachusetts, again, accidentally with this DSRIP funding that went to ACOs. The ideal is to have a model in there to advance the cultural and systems level change within healthcare itself. That's kind of the holy grail, the pot of gold at the end of the rainbow, and sort of takes a lot of work and thinking to get to. Before you get to that, if you have a CHW supervisor who understands the supervisor or the CHW role and can advocate for that CHW within the healthcare system, that's been shown to be a really big lever, important lever for CHW retention and effectiveness. So what my team did, we actually came in and we expanded the core competency trainings that were available for CHWs in Massachusetts. So at the time, this training network existed, but it suffered from sort of the same fractures of grant funding that the CHW role had funded from. So we kind of put an infusion of cash in there to just double or triple the number of CHW core competency trainings that were available. We also, and I honestly think this is the most important thing that we did, we funded the design of a CHW of a training for supervisors of CHWs, which hadn't existed in any consistent way before in the state, and then rolled that out over 4 years of the waiver. We also funded a host of advanced trainings for CHWs in serious mental illness, substance use disorder, and then when the pandemic hit, telehealth. That's the programs that I ran. Yep. I'll skip over. Credentials and data are really important if you're advocating within Medicaid programs. So that is the language that Medicaid speaks, and we can come back to that in questions, certainly. And I will end with this. I will kind of wrap up with the story of what happened in the next waiver for community health workers in Massachusetts. Basically, we jumped to, I think Carl referenced this in his talk, we continued. Again, remember that Massachusetts was really sort of went all in on making this shift from fee for service to value-based payment. In our effort to continue funding those CHW positions that had been started with that $1 billion in DSRIP funding, we sort of doubled down again on that notion of value-based payment, right? We don't want to tether any part of our healthcare system to that fee-for-service payment mechanism any more than we absolutely have to. And so what we did was, instead of coming up with a reimbursement mechanism for CHWs, we put something in place called subcapitation. So we authorize, so subcapitation is basically PMPM or kind of blocks of funding. And in our case, that went to the provider organizations themselves. So skipped over that $1 billion in sort of ACO funding, went to the ACO management up here with subcapitated funding in our current waiver, which started in October. The provider organizations actually get a block of funding that they can use flexibly, however they choose. Nowhere in the waiver does it explicitly say financing for CHWs, but as we were designing this subcapitation model, I think the ability to fund CHW roles, positions through this subcapitation payment was front and center in every policy discussion. I would say, just in terms of, again, if you're thinking about discussions and advocacy within Medicaid, the biggest advocates externally for this subcapitation model were federally qualified health centers, which historically have been ahead of the curve in terms of employing CHWs and really knowing their value. Pulling back the curtain and looking within our Medicaid policy design team, the biggest champion for this subcapitation model within MassHealth, and really one of the primary architects of it, was a primary care physician who had his clinical practice at a community health center that was known even among community health centers for really relying on community health workers and using them, sort of supporting them in a really appropriate and forward-looking way. I know we're at time. I can also at some point, and we also continued our investments in, thank you, got it. We also continued our investments in training for CHWs. So I know I'm at time and can answer questions along with Carl.
We do want to just step up and announce a slight scheduling change because of lunch running over a little bit. We are going to go for 8 more minutes, so we have time for questions, and we will take a break immediately following that. So if anyone has questions, I would welcome you to come up to this mic, please. Last plug, please take an evaluation with you on your way out there on the tables. Who has questions for our fabulous experts? Yeah, so can you, yeah. Yeah. So Carl, the question is, it can be a really big billing call. So the questioner has heard that it can be a really big lift
to get a Medicaid billing code for the work that CHWs do. Is that, can we speak to that?
Well, when you say billing code, the state can specify what the billing code is that you would use. So I'm not sure we're talking about the same thing. Normally we talk about there are two coding systems that are used to say what service is being billed for. And most states have one code that the employer or provider uses to bill for that service. So that's something the state obtains. And when you say to get a billing code, whose point of view are you talking about?
Yeah. Yeah. I can try to respond. So there's sort of different ways. So Carl had it up on his slide, right? There's two main ways that states have used to sort of be able to finance CHW positions. The one that you're referencing, I believe, is the state plan amendment, right? Which will enable, Carl, I'm gonna turn this over to you at the end to correct anything I misstate, but that is the approach. It's not the approach that we took in Massachusetts. That's the approach where you would basically get permission from the federal government. You get approval from the federal government to be able to bill Medicaid for services provided by a CHW. Medicaid would reimburse the healthcare organization or the individual for those services that were provided. That's typically the way that doctors are reimbursed right now, nurses, so on and so forth. That's sort of a standard reimbursement model. To actually sort of get those reimbursements, you have what are called billing codes, right? So what I think what you're talking about is sort of, if you have that state plan amendment in place, what are the billing codes that are layered over that? And I think the question that you're asking is, CHWs do their work differently than doctors and nurses, right? Going back to that, CHWs are not traditional healthcare providers. And I think what you're asking is, how can you sort of set up a state plan amendment where you're getting reimbursements from Medicaid for CHWs in a way that enables them to work as a CHW, not trying to fit them into the mold of a doctor or nurse. Is that a correct sort of interpretation? Yeah. 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 I think with Medicaid, and again, I'm going to pause so Carl can correct me if I if I say anything wrong at the end. I think with Medicaid, you're always going to be in the details, right? So it's great to have the ideas up here. I think to implement Medicaid, you're always going, or for a very long time, let's say, you're going to be in those weeds. And I think for a very long time, it will be state by state, because Medicaid is inherently, it's a state and federal program, right? So half the money comes from the federal government, half comes from the states roughly. And so you kind of know one Medicaid program in one state, and it's different when you go to the state next door because of all these modifications that they've made. To go to your other question of, which I think is kind of, can you do this billing code thing, right? This reimbursement in a way that honors the work of community health workers? I would say you can. I'm also working in Rhode Island right now. They just got estate plan amendments, so reimbursements for CHW services from Medicaid. I think it's an amazing benefit. Carl was actually, I think, one of the architects of it, so he can probably talk about the how-to much better than I can. But it really honors the way that community health workers do their work. And it reimburses community health workers at a rate that's actually sustainable, which is rare for Medicaid. So Carl, did I get anything wrong? Or do you want to add?
No, I think it was very good, and we're short on time, but the state will choose if they adopt either through a waiver or a state plan amendment, they will choose how providers get paid. And if it's fee for service, then they submit claims after the services are provided. And the billing code defines a category of services that are being billed for. In most of the states that have these state plan amendments, that billing code is for something they call patient self-management education. And what's really important is how the state interprets that, because most states define the range of what CHWs can do much more broadly than that code definition would suggest. So if you look at the provider manual for Rhode Island, and I think you would agree with me on this, Tara, that they describe a range of services that is quite broad. Now, they did not use that same code, but the code they used is technically a fairly narrow definition. They used what's called a HCPCS code rather than a CPT code. And what's important is the code is just a code. You got to use it to submit a claim. But what matters is the provider manual tells you what CHW services can be billed for under that code. That's what's really important. And so that's really crucial to the whole system, regardless of how you do it. A system like what Massachusetts proposes, which is kind of similar to what Maine has done, doesn't have that kind of, the billing provider has a lot more flexibility in what they can have the CHWs doing. And so they don't have to worry about that. But in a fee-for-service system, you typically only have one code you bill on. There's no discretion. You just put that code on the form, and that's it. So there's not a lot of, you don't have to wiggle a lot. If you're having CHWs do what's allowed in the provider manual, you're good. That's it.
With that, folks, well, we are at time. If you all don't want to take your break, you're welcome to keep asking questions. If you would like to take your break, I want to let folks dismiss. I'm sorry. I know this was such like the beginnings of a discussion. So I just want to invite everybody. There's more information forthcoming about Medicaid. There are ways to get involved in the statewide network formation and other pieces. And I am also willing to stick around and talk and help connect folks to our presenters afterwards. So thank you all so much. Thank you to both of our presenters. And so the next thing starts at 2:50 back in the big ballroom. Please take an evaluation with you on your way out. Or I'll have to come find you in the big ballroom with one.